So good evening to everybody, members of DCB Academy. Today, Dr. Silvia Ivancic will present some information about all we need to know about microvascular disease. This often forgotten entity in interventional cardiology is something where we don't have to dilate a stent or a balloon, but it's something different, but still something that we need to manage for our patients. So Silvia, please.
Thank you very much. It's my pleasure to present this topic today. I also think it's very important part of cardiology, also interventional cardiology last years. It is developing all the time, so it's good for the patients. Let me present very shortly how looks the coronary circulation generally. So we have epicardial arteries, but we have to remember that we have also the small arteries, intermediate arterioles, small arterioles, capillaries, and veins. And epicardial arteries are generally only a small part of the coronary circulation generally. So we have to remember that we have a microcirculation, and each part of this vessels are responsible for different task. And epicardial arteries are the large arteries, more than 200 microns, are responsible for transport of the blood. And the small arteries are responsible for a regulation of the circulation and myocardial supplying, and of course the capillaries for the exchange of the oxygen. And this is a very well-known picture for all of us. These are epicardial coronary arteries in coronary artery coronary angiography, but it's not a full view of the coronary circulation. Please let's look at these pictures, and at this one we can see whole coronary circulation, including microcirculation, and there is no doubt that this is very important part of coronary circulation, as you can see, and it's associated with the myocardial supplying for sure. So we'll talk about this part of circulation today mostly, and the problem with dealing with this part of circulation is that it's quite difficult to diagnose this disturbance, microcirculation disturbance in very in echocardiography, for example, or other imaging examination, because the changes in the coronary arteries are generally more diffused, and the ischemia of the myocardium is also more diffused. In coronary artery disease, as you can see in this picture, when we have a coronary stenosis, the ischemia of the myocardium is rather global or segmental, so it's better. And so we can we see myocardial ischemia and contractility disturbance in echocardiography or other imaging tests. But for microvascular disease, it's more difficult, and there is no diagnostic tools, imaging tools to visualize directly the microvascular disease. So, of course, the ischemia it's related with the mismatch between supplying and demanding of the blood. So, as I said before, the coronary in the coronary artery disease, we have a global or regional ischemia associated with inadequate perfusion of the perfusion of the myocardium. In microcirculation, the process are rather local and connected with the inadequate distribution of the flow and functional, for example, functional shunting. So as you can see, there is a lot of determinants of myocardial oxygen supply and demand. So there is a processes associated with the vascular resistance, like perfusion pressure, like extravascular compressive forces, neurohormonal factors, endothelial factors, and the factors associated with the coronary blood flow, or of course with demand of the myocardium due to heart rate, contractility, external warp, etc. So very important it's to remember that the microcirculation, it's not a miniature of the microcirculation. It's a different type of vessels regulated by the different processes. We also need to use different tools to diagnose the disease of the microcirculation. So we can divide the disease of microcirculation into two types. The type 1, it's associated with the generally impairment of flow in the microcirculation due to the microvascular occlusion, systemic embolism, ischemia, reperfusion injury, generally in patients with acute coronary syndrome with ST segment elevation myocardial infarction, and with the vascular remodeling associated with some systemic disease, including those leading to left ventricular hypertrophy or inflammation like hypertrophic cardiomyopathy, aortic stenosis, arterial hypertension, myocarditis, vasculitis, the diabetes. So there we have, in this type, we have a remodeling of the microcirculation. And in this group of patients, we should diagnose them assessing the coronary flow reserve. I will present, of course, these techniques in the next slides, but this is the generally the first information about this. So the assessment is the assessment of the coronary flow reserve and the minimal microvascular resistance. And when we have an EMR more than 25 units and CFR is less than 2, we can recognize impaired microcirculation. The type 2 is rather associated with the endothelial dysfunction, vascular smooth muscle cells dysfunction. So we don't observe in this patient a remodeling, but rather functional disease. And in this group of patients, the selective intracoronary administration of acetylocholine is the best way to diagnose this type of disease. So acetylocholine provocation test, it's the examination test. So and we have diagnosed microcirculation spasm, so dysfunction of this part of circulation when we have angina symptoms with or without ECG changes, or associated with and without the reduction of coronary blood flow velocity. If we have a Doppler examination at the same time, but generally without the reduction of the coronary diameter during the test, or the reduction less than 90%. So this is a type, the example of type 1 microcirculation disease. Please appreciate on the left side that there is a decreased capillary density. So this is a first type of remodeling of microcoronary circulation. So we have decreased the capillaries, and on the right side you can observe the increased thickness of the wall of the capillaries. So the arterial obliteration index is increased in the patient with type 1 microcirculation disease. And one more time, Escanet showed in his study that in patients with hypertension, as you can see here on the right side, the density of capillaries is also decreased compared with control patient without the hypertension, and also the wall, the thickness of the wall of capillaries is also increased. So it's there is a remodeling of the artery wall in this group of patients. Why it's so important? Because it's one of the pathomechanism of myocardial ischemia in patients without the coronary artery disease, without the stenosis of coronary arteries, so the INOCA patients. We know that the angina pectoris affects about 112 million people globally, and up to 70% undergoing coronary angiography because of angina, and evidence of myocardial ischemia do not have
Silvia, sorry. I would say that up to 70 according to some studies, but usually this number is much lower in routine practice, because
yes.
this means that you have not done a correct milieu of examinations before arriving at coronary angiography if you find such big numbers.
Yes, I show that in the next slide also.
All right, sorry.
On this slide it's better. Yeah, as you said, the rate of the group without with normal coronary arteries, it's different for different studies. Like this study, it's about 40% of patients. But what it's interesting that look at these results, that in group of patients with positive stress test, that there is in only a little more than 50% of patients there is a obstructive coronary artery disease. So in a little bit more than 40 patients, the coronary arteries are normal. So let me back to the INOCA consequences very shortly. As we said before, INOCA is rarely misdiagnosed. It's not correctly diagnosed. So we have no proper therapy for this patient prescribed. So very often the patients continue to experience recurrent angina with really impaired quality of life. We have to face with the repeated hospitalization, unnecessary coronary angiography, and adverse cardiovascular outcomes in short and long-term observation. Also, the problem is paradoxical reassurance by the treating physician, and physician may even refute the underlying symptoms. It's also a problem for some patients. So there is a lot of different factors which are speculated. Most of them, or some of them, are associated with the female gender. So like like menstruation disorders, infertility, etc. So we observe generally that the INOCA it's diagnosed significantly more often in female groups. So probably there's some sex-associated factors are also important in the pathogenesis of INOCA and microvascular disease. What about the diagnostics? Generally, the first steps of diagnosis, like a patient evaluation and non-invasive evaluation, are the same for all patients according to the guidelines. So, of course, we can do in the first step the non-invasive test. It depends on the probability of disease before the test. So we can use coronary computed tomography angiography in patient with the low clinical likelihood and rather functional imaging in patient with high clinical likelihood of coronary artery disease. But as I said before, this non-invasive evaluation, it's difficult regarding the microvascular disease diagnosis. Now there are some possibilities in magnetic resonance imaging because there are some ways to assess quantitative assessment of the ischemia of the myocardium ischemia assessment. So and some softwares which help to diagnose microcirculation disease, but it's not routinely used now. And generally the gold standards of diagnosis this group of patients still is invasive coronary angiography with functional tests. So the patient with high probability of coronary artery disease undergo coronary angiography, and in patients in whom normal or mild coronary artery stenosis is visualized, this group of patients should be evaluated with the functional test of coronary arteries. And the first step, the first functional test which should be used is adenosine test. It's the test with allow to assess coronary flow reserve and index of microvascular resistance. As I said before, it depends on the value of CFR and EMR. We can recognize microvascular dysfunction or not. Well, when we have a coronary flow reserve less than 2 or EMR is more than 25, we can diagnose microvascular dysfunction. The next step, we should do this test during the same coronary angiography. So generally and mostly in most cath labs, the adenosine test is performed as a first. And the next is performing acetyl-CoA test. And based on the results of this test, we can diagnose the patient. And when we have a negative acetyl-CoA test and negative adenosine test, we can say that the patient that the pain, it's not cardiac pain. When we have a reduction in diameter more than coronary diameter more than 90%, plus angina and plus ischemic ECG changes, we can recognize epicardial vasospastic angina. when we have a reduction of coronary artery diameter less than 90%, and no angina, no ischemic changes, or and the positive EMR adenosine test, we can diagnose microvascular angina, and these symptoms can be mixed, and
But
we can
this is
recognize.
something that I don't understand here, Sylvia. How can you diagnose microvascular angina if the patient is asymptomatic?
We can diagnose it based on the adenosine test, for example.
Yeah. But by the name, if one is
that's right.
asymptomatic, cannot have angina. So microvascular ischemia, we could call it.
Microvascular ischemia. That's right. I
Yeah.
agree with you. That's right. That's right. Yeah. This is a consensus of the oh my God, I forgot the name. This is the consensus from the Euro intervention, but
Yeah.
I agree
Yeah,
with
it's Inoka group. Yeah, I don't know.
Kovadi's group. Yes, that's right. But of course, I agree that the angina it's improper here, but ischemia it's rather about the ischemia, not angina. I would like to say a few words about assessment of CFR and microvascular.
Go ahead, but try to condense in 2 minutes all the rest, please.
Okay. So this is an invasive assessment during the coronary angiography. So it's quite easy to perform. First of all, we have to use a guide catheter. Generally, we assess this EMR and CFR in LAD because it's supplying the biggest area of the corner of the myocardium, and we are going with the special guide wire into the LAD distally as much as possible, and after that. We are giving a saline, about 3 milliliters of saline in the room temperature very quickly to the coronary artery. And after the first, I will show you on this picture. This is final results, final graph with the results. So the first of all, we are doing the measurements during the rest. So in standard condition, the patient is lying on the table, and we are performing the first measurements, giving the saline into the coronary artery very quickly. And we have some curves here. We would like to have 3 similar curves during this measurement, and these 3 measurements are analyzed in the next step. And after that, we induce hyperemia. Hyperemia is induced by adenosine injection, intravenous injection, or regadenoson injection. We use Rapiscan regadenoson injection. It's giving intravenously in one shot. And after 1-2 minutes, we can assess the hyperemic parameters. And one more time, we're giving the saline into the coronary artery very quickly to get the similar results of this is a okay. So, after the hyperemia, after that, generally we have the system shows the results And what we have here, there is a FFR, of course, fractional flow reserve. We have a CFR. The normal range is more than 2, and EMR, the normal range is less than 25. And based on this result, we can diagnose the patient. So it's very generally it's quite easy functional test.
So in this case, we have a CFR below 2, so it's
Yes.
1.3. And this is the first parameter. The second parameter is the IMR. So which is the cutoff of the IMR?
25.
So high IMR. So
yeah.
here the diagnosis of microvascular ischemia. I don't know if this patient had angina or not, but angina is done.
Yes, that's right. This is a patient with angina and very high EMR, so this is a microvascular angina.
Yeah.
Diagnosis in this patient. So what about the treatment? Generally lifestyle factors modification and risk factors modification, like because the patient very often has hypertension and comorbidities like dyslipidemia and diabetes mellitus, so we have to treat all of them properly. There is a lot of speculation about the anti-anginal medication and this pharmacological treatment. We still don't have enough about the effectiveness of these drugs in this group of patients, but generally in patients with microvascular angina, we should use it's preferred to use beta blockers, calcium channel blockers, nicorandil is also effective in some group of patients, ranolazine, ivabradine, or trimetazidine. It depends which drugs are available in country, because it's not so easy to get these drugs.
Yeah, these are just symptom controller drugs.
Yeah, that's right.
Yeah, and not all of them have a proper evidence-based medicine, I would say.
There is some studies which show that the ranolazine in trimetazidine, it's effective in relieve the angina, but ranolazine in Poland, it's very expensive. So it's really difficult to.
So which is your first choice? It's a beta blocker?
It depends on the results of the test, because when we have a type 2 myocardial dysfunction, microvascular disease, so the EMR it's more than 25 or CFR is less than 2. I prefer beta blockers and ACE inhibitors, and trimetazidine as a second choice. And when I have a patient with positive acetylcholine test regarding the microvascular dysfunction, so we have a spasm less than 90%, but we have a chest pain or ECG changes during the test, I can diagnose functional disturbance in microcirculation, and in this patient, I prefer calcium channel blockers, like in patient with vasospastic angina. So,
yeah, so you mean verapamil or diltiazem, so non-dihydropyridines.
Yeah. That's right. So sometimes nitrate also are effective in this group of patients, and in some of them, because I observe a group of about 40 patients, which whose I diagnosed with about the regarding microvascular disease, and very often I have to add dihydropyridine calcium channel blockers to the beta blocker, and then it's effective. So it's quite very difficult, but when we have a patient with diagnosed microvascular disease, it's easier for us to modify the treatment, to add to the next drug. Yes, because we know that the patient that's ill the patients have a problem with microcirculation, and we have a focus on the treatment, pharmacological treatment, and not afraid to give the next drugs for
Okay.
them. So I think it's very important. Okay,
Okay, thank you. We want to see you now. Where are you? You disappeared.
oh, all right, okay. Oh,
So thank you for this very nice presentation. Alessandra wrote that had to leave, and also somebody else is lacking now. But I think you gave us some good suggestions on how to understand and manage this disease, which is, as you said, quite common. Some cases up to 50% of the geographies as come into the cath lab have some negative epicardial disease, and some of these patients, at least those that have symptoms, should undergo advanced diagnosis like the ones that you have shown. So thanks for that. I would like to ask you guys, Sarah, Wojciech, Amit, Leo, Krupal, Antoine, and Rima, if you have questions for Sylvia. I think there are many questions arising, so you should have some.
It's a big topic, and Sylvia is an expert in the microcirculation disease. And what can I say? For me, it's quite interesting. The patients with myocarditis. There is no any study which has been performed in myocarditis, but probably for sure there is the problem with the microcirculation, and patients with myocarditis is not so small group of patients. And what's your opinion? Should we perform should we test or perform those kind of tests in patients with myocarditis, or we should perform such study, or something like that should be performed? And also the question, what's your opinion about the treatment of the patients with myocarditis, which probably also have the problem with the microcirculation? Do you have any idea, or any have you had such kind of the patient? But because I know that there is no any study with patients with microcirculation and microcirculation disease and myocarditis, but in my opinion, it could be also the interesting topic.
Yes, I agree. Of course, Wojciech, that this is a special group of patients in which the coronary microcirculation, I think it's diseased very often, but I think it's not. It's really difficult to distinguish if we have to manage with the microcirculation disease because of the myocarditis and other mechanism like a myocytes edema. This type of
the main difference, I think, is that with myocarditis, the disease is often temporary.
Yeah.
So unless the patient has some complications, the edema is going, and the infection itself is going to relieve, leaving often a scar, but which has nothing to do with a microvascular dysfunction. It should be interesting to understand those patients that have still a microvascular disease persisting after myocarditis due to probably longer term inflammation or some immune reaction also. Why not? That could lead to disease of the microcirculation. I think this is a niche category of patients that are not well studied. I agree.
I think also that the very important will be the checking if the coronary microcirculation disease in the acute phase is associated with the prognosis of this patient, like inpatient, for example, in STEMI. In STEMI group, when we have a very high EMR in the acute phase, the prognosis of this patient is worse. The ischemia and the the risk of scar and remodeling with the myocardial with the heart failure is also increased in the observation. So it can be also interesting if we have any connection with the prognosis.
Yeah. Other
Congrats,
points?
Sylvia. Shadak.
Ciao.
I would like to ask you, how often do you use a microvascular disease test in your cath lab? Do you routinely use it when you have a negative epicardial disease? I mean, if you have like 10 cases a day and 4 are negative epicardial disease, how often and how do you select the ones that you test for microvascular disease?
Okay, thank you. So I had a small break in the cath lab now. So, but before that, I tried. Unfortunately, it was very difficult to do the test during the same coronarography, without the coronary artery disease. So generally, very often I plan the second coronary angiography with the functional test. So before I left cath lab about 1 year ago, I did about 50 functional tests in my patients. So it's quite often. In some group of them, I also did magnetic resonance to compare the results of microcirculation disease in invasive and non-invasive tests. So we will publish this results in the coming months, I think. And I try to focus also in some specific group of patients. So now I am dealing with patient with coronary aneurysm and microcirculation disease, also with the patient with the woman treated with anthracyclines because of the cancer. So I have some specific groups of patients in which
but as you said, this is left to your sensibility to this disease. I believe that also Leo, what he was meaning is also true, that in a busy cath lab, it's not easy if you have a case of negative coronary artery disease at 10 a.m. to do everything, because you would have your colleagues knocking at your door saying, come on, finish this because we want to do TAVI or PCI or whatever. And so, as you said, also, you have to reschedule a second examination, probably the following day at 7 p.m., because these cases are put at the end of the day after the interventions or the urgencies. So, yeah, this is quite normal, I think, in many cath labs.
Yes.
Yeah.
Thanks.
Yeah, so I would like, Elisa, you can stop the recording.